session, we're going to discuss the contributing factors to periodontal disease. These are factors which in themselves do not initiate, but rather predispose or modify the progression of periodontal disease. There are two such factors. We can lump them into two groups. The first group are the local factors. Those exist within the oral cavity. And the second group are the systemic factors. The local factors include such factors as incorrect toothbrushing, occlusal trauma, food impaction, mouth breathings, and iatrogenic dentistry. In this image, you can see the result of incorrect toothbrushing resulting in tooth abrasion. Patients often brush teeth incorrectly with very hard toothbrush, and this leads to gingival recession and wear facets exposing the roots of the teeth. In a normal alignment, teeth touch each other very tightly. When the contact is slightly open between the two teeth, that results in food impaction, which can damage the gingival tissues. This picture illustrates caries, which results in open contact. Another contributing local factor is the iatrogenic factor. These are incorrectly constructed restorations with overhanging ledges, overbulking contours, incomplete seal, improper occlusion. Those may actually contribute to gum inflammation by trapping bacterial plaque and rendering its removal very challenging to the patient. Occlusal trauma is another factor, and it is defined as injury to attachment apparatus as a result of excessive occlusal force. There are two types of occlusal trauma. In primary occlusal trauma, the forces acting on teeth exceed their capacity, and secondary occlusal trauma, these are normal occlusal forces acting on a weakened periodontium. The best way to explain would be a very heavy person sitting on a regular, well-constructed chair and breaking the chair. Secondary occlusal trauma would be akin to a normal person with normal weight sitting on a damaged chair and breaking. In both cases, the result is the same, but the cause is quite different. So while occlusal trauma does not initiate or accelerate inflammatory effect of periodontal disease, it may have an adverse effect on the supporting bone of the tooth and increase its mobility. These pictures on occlusal trauma demonstrate what happens when posterior teeth are extracted without subsequently being replaced. The occlusal forces are shifted to the anterior teeth, which are unable to withstand the pressure. As a result, these teeth drift, spread, and become loose. The lower jaw overcloses, and the ability to chew food is severely compromised. This condition is known as posterior bite collapse, and it often happens in those patients who extract their back teeth and are not willing to have them replaced. The systemic factors include age, smoking, diabetes mellitus, pregnancy, puberty, stress, genetics, and heredity. Older people have higher rate of periodontal disease. Center of Disease Control estimates that over 70% of Americans 65 years and older have periodontitis. Keep in mind, however, that association is just that. It is not an indication of cause and effect. Diabetes is another significant factor in periodontitis. Diabetics have more severe and prevalent form of periodontitis. Patients with diabetes have a faster rate of bone loss. Diabetic patients with periodontitis also have a higher rate of acute infections, such as abscesses, and experience delayed healing following treatment. While periodontal destruction in diabetes relates to metabolic control, periodontal infection adversely affects glycemic control. Hence, improvement in one factor leads to improvement in the other. Patients who have interleukin-1 genotype positive have an increased inflammatory response in the presence of bacteria, increased amount of pathogens, and are an increased risk for severe periodontal disease. Above patients are less likely to respond favorably to periodontal therapy. It is important to remember that the role of genetics in periodontitis is a disease modifier. That means bacteria must be present for the disease initiation, but modifiers such as genetics alter the body's response to the bacterial challenge. Smoking is another important factor in pathogenesis of periodontitis. There is a strong correlation between smoking and periodontal disease. In smokers have smaller reduction in pocket depth following surgery, and there's also a poorer reduction in bleeding and probing depth following scaling and root planing. What are the mechanisms of tobacco smoking? Well, periodontal pockets of smokers have more anaerobic bacteria, which are the more pathogenic bacteria. They have decreased amount of salivary antibodies, such as IgA and IgG. They have fewer helper T lymphocytes, depressed chemotaxis and phagocytosis of following morphonucleosides, and exert direct effect on periodontal tissues attachment to fibroblasts, therefore impaired ability to synthesize collagen and hence impaired ability to heal. Emotional stress is a significant factor in many diseases, and periodontitis is no exception. Emotional stress has been linked to hypertension, cancer, and compromised immune system. In the oral cavity, a strong correlation between necrotizing infection and stress has been established. Hematologic factors have also an important influence. In leukemia and various forms of neutrophil dysfunction, there is increased rate of periodontitis, bone resorption, and bleeding. There's a whole host of medications which can contribute to gingival pathology. Let's review them briefly. The calcium channel blocker medications, which are used for hypertension, results in swollen and bleeding gums. Anti-seizure medications such as Dilantin have effect of gingival hyperplasia and hypertrophy. Anti-organ rejection drugs used in organ transplantation such as cyclosporin have similar effects. And last but not least, oral contraceptives and antidepressants used by many patients result in dry mouth, which result in increased gingival inflammation. Poor nutrition also can compromise the body's immune system. Obesity may increase the risk of periodontal disease, and vitamin C deficiency, such as scurvy, can lead to gingival inflammation, collagen deprivation, and tooth loss. There are other conditions which have been also associated with periodontitis, and those are being currently investigated. One is osteoporosis and periodontal bone loss, association between oral bacteria and respiratory disease, gum disease and cancer of the kidney, pancreas, and blood. The common denominator that links periodontal disease and other diseases is the state of inflammation, and this area is under current research.